Hello, everyone. Welcome back to our series on CMS and their health equity physician fee schedule changes. As you know, in our first session, we just did an overview of what we were going to talk about, and we planned 4 total of these discussion sessions between Melissa and myself, and anyone else who wants to be involved with us, just let us know. But this session, we're going to talk about principal illness navigation and what that means for patient advocates and patients and anyone who has access, is able to access these services through Medicare. So I'm going to share my screen, and we are going to do a little bit of a PowerPoint because let's see if I can get this up here, because there's so much in the details, right, Melissa, that we want to be able to share with you. And it's important to understand and know the details, because that will help you, understand if it can apply to your practice and how it can help your patients. So again, Melissa and I are here. We are the co-founders of the Bridge Health Advocates, where we train medical professionals to work as independent patient advocates. And we just, are so involved in this world of healthcare and change in healthcare and patient advocacy. And so we're always happy to be talking about these things and researching them and just, starting a discussion if we can. So just to, again, refresh your memory, there's the 4 new services that address health equity by Centers for Medicare and Medicaid Services, CMS. First one is the caregiver training services. Then there's a social determinants of health risk assessment, community health integration, and then principal illness navigation. And for some reason, we're starting at the bottom with principal illness navigation. And then we are going to address the community health integration too, but social determinants of health, we'll talk about that a little bit with community health integration. And then caregiver training services, if that's something you're interested in, we can look into that too for you. But right now we have planned to address number 3 and 4 in our series. Okay. So first, principal illness navigation. What is this? What does CMS have to say about it? It's navigation services in the treatment of and this is the most important word, a serious health risk condition or illness. So services that guide the patient through their course of care, including addressing any unmet social needs that significantly limit the practitioner's ability to diagnose or treat the condition. So again, I said it's one condition. So PIN services include items like health system navigation, person-centered planning, identifying and referring patient or caregiver or family to supportive services, other care coordination and communication between providers, whether it's at home or community-based, patient self-advocacy promotion. So in the patient advocacy world, we talk a lot about empowerment, and that's what that sentence is to me, is empowering our clients, our patients. And then community-based resources, accessing facilitation of that. So that's kind of where we are for what the principal illness navigation is. Melissa, how do you think these services are similar or different to what patient advocates do, or how would you compare them?
Sure. So when I first saw the fee schedule with principal illness navigation, really, I just went into my background and tried to put this more into, okay, what does this really mean for patients? And where this historically came from really is the oncology world. So when we see somebody who has a diagnosis, a cancer diagnosis, and that's that like one high risk condition or illness. And as a practitioner, so, a physician, a nurse practitioner, a PA, a nurse, they identify that this patient really is at risk for being hospitalized, or their condition going the way we don't want it to go, that historically we jump in anyways, and we realize that we need to make sure that this patient has the services they need. And so these type of services have already been provided in our healthcare world. It's just we haven't been reimbursed for them. So when I saw this pin, that was the first thing that came to my mind was the oncology world, and that we're now seeing recognition that if a provider identifies this person's really at risk, we really need to spend some time to make sure that they're getting the care that they need. And it's pretty intense, right? So, identifying or referring patient and caregiver to supportive services. Well, are they getting to their appointments? Do they have the emotional support to go through this? Do they have the financial support they need to go through this? So, it's actually exciting to see that this is out there, and especially coming from the healthcare world. My background being a wound ostomy nurse, we would see this sometimes in our wound clinic where somebody would have a change of condition with arterial disease. And it really was intense going, wow, we need to get them in right away for, Doppler studies and interventions. And it really required the office staff, right, to step in and work with the patient on making sure that all of their needs are being met.
Mhm. And definitely, you're a nurse advocate, nurse patient advocate, and a lot of what you do is, you know, directly related to what these, the PIN services that are listed here. I know as an independent advocate, you go above and beyond,
Yeah,
with what you're doing for your clients, but you're definitely incorporating, what is in this list. I mean, you do the comprehensive assessments, addressing social determinants of health, and then more and more, you're creating that personalized care plan for them, and just ensuring that everyone is collaborating, informed, you're facilitating communication. It's a lot of overlap, with what they.
absolutely. And that's how, when I designed patient advocacy in my world, in my mind, it really came from that experience working in the healthcare system.
Mhm.
And, as much as we want to assist as providers, as nurses, case managers, social workers, a lot of times there is a limit to the amount of assistance that we can provide. For example, in an 8-hour day, you can't spend an hour trying to get somebody transport to dialysis. You just can't.
Mhm.
And so that's where I think this stemmed from is a lot of the work that we know is being done by healthcare providers. And then patient advocacy, independent patient advocacy, the reason we designed this was because I know that they're doing the best they can during their job, but again, they can't be sitting on the phone and researching and doing this stuff. And so any gaps that we can help um as an independent advocate is what we do for clients.
Yeah, absolutely. So let's move on to who does it. So who is CMS envisioning, is going to actually be providing these principal illness navigation services? So they are saying that it's auxiliary personnel. So what is auxiliary personnel? So they're calling them care navigators. So these are also known as the PINs, the principal illness navigators. And then they have it broken down into peer support specialists too. So the PINs I kind of see as this generalist navigator, and then the peer support specialist, also known as PIN PS, that they are specifically for patients with high risk behavioral health conditions. So they're a little bit different, and they're differentiated by reimbursement codes that you're going to use, and by some of the training. So we'll see that. Um, these auxiliary personnel, they can be external to and under contract with the practitioner or their practice. So they don't have to be employed by them. They don't have to be in-house. They can be, under contract with them. So there is some training that CMS recommends, and I would say, it's fairly vague, but it's all stuff that we in the Bridge Health Advocates that we do for our clients, when we train them. So PINs have to be trained or certified in patient and family communication, relationship building, patient and family capacity building, services coordination, patient advocacy listed right there, facilitation, individual and community assessment, professionalism and ethical conduct, of course. I mean, you and I are both board certified patient advocates. We have a code of conduct that we adhere to, as all advocates should, development of a knowledge base, including specific certification or training on the serious high-risk condition, illness, or disease that's being addressed. And for the PIN-PS, again, they're addressing the behavioral health conditions. Their training needs to be consistent with the national model standards for peer support certification published by Substance Abuse Mental Health Services Administration, SAMHSA. So they do have apparently a national model that CMS is saying, you have to follow that for your training to provide those services as a PIN PS. So what are your thoughts on the training requirement, Melissa?
I think it's very vague.
Yeah.
And this is, that's why we're here, is to really sort of go through this and try to understand it and actually apply it. So when I read this again, I go to, so what about the nurse navigator who works at a cancer center,
Mm-hmm.
right? And they are going to be doing these type of services. So do they need to be trained, or, by default, by being a licensed nurse or social worker, are they already trained
Mm-hmm.
to do this? And then again, so is CMS saying, okay, if you're a nurse, a social worker, you can do this, but if you're also a lay person, as long as you go through training, are you able to provide these services? And I think that's where we're trying to understand better, right? We're reaching out and seeing how this is actually being implemented. Again, that oncology world is where
Mm-hmm.
a lot of this stemmed from. So, they, how are they doing the training? How are they implementing it into their uh, practices? So if you're an oncologist, right, how are you implementing PIN into your oncology practice?
Mm-hmm.
Who is providing the services? Is it a registered nurse? Is it somebody that internally you've trained to do this?
Mm-hmm.
So it just brings up a lot of um, questions on training, certifications. If you're already a licensed professional, what does that mean?
Mm-hmm.
Um,
And so CMS does say, and I didn't write it here, that if your state has a certification in it, a licensure, then you do need to be certified, within your state. I did a search and I couldn't find any states that had a certification specifically for principal illness navigators. So I don't know if they're going to pop up in the future or
yep.
who's going to be developing them, but I couldn't find them. And so if anybody does know of state training specifically for this, let us know. We would be, really interested to learn about that. But I hadn't found, any. I do believe Oncology Nursing Association Society, I'm
Mhm.
forgetting the title, society, I believe, they do have a training that they developed, core competencies in it, and a training for oncology navigators. And I
Yes.
think I think that's in our resource list that you guys, everyone should, go find. We'll put the links in all the social media stuff. But I think it was 2017, I saw a big, PDF for their training. Is that right?
Yep. Yep. 2017 is the last time they
Just updated it.
updated their training.
Hmm.
I foresee that that's probably going to be looked at again now
Yeah.
with PIN, right, coming out. There is a letter that they did write to CMS, and part of that letter is what I mentioned previously is, okay, does this include a registered nurse or a licensed social worker who are providing these services? Do we also need to be trained? And again, will that training come in, internally from that organization?
Mhm.
And as you mentioned, Jennifer, it's also state by state. So,
Yeah.
what happens if there's overlap amongst states or that? So, again, we're here today just to sort of start diving into this. But depending on where you live and you practice, might also depend on how this is being rolled out, who can provide the services.
Mhm.
Um, and it's a great opportunity to reach out to others in the industry, and have dialogue with them
Mhm.
on, are you offering these type of services? What does it look like? Always thinking about the patient. So what does this mean for the patient? Can you just tell me more? We've identified, so for example, if we're working with somebody, right, who has a diagnosis, right, of cancer, but it's exacerbated, it has now become, oh my gosh, we really need to assist, right? There's that sort of change in condition where to me that's when these type of services would be implemented, and then who is going to provide them? Will they be directly provided by that oncology office? Will
Mhm.
it maybe possibly be a cancer society?
Mhm.
Um, so yeah, a lot
And
of questions and
mhm. But it's good. I mean, this is happening right now, and people who are invested in it can get involved and help shape the future of what this looks like. And, this
yeah,
came up in another article that we read. I think it was in the Cancer Letter. About are we by CMS, implementing this reimbursement, we are creating a quote unquote durable workforce, right? So we're
exactly.
going to
Right.
have people who want to go into this. They know that they're going to get paid. This is their interest, their love, and they're like, okay, I can do this, and this is, a real career. And then it's something that is just this CMS, they do a lot of innovative
Yeah.
things around reimbursement. And so it's like, okay, maybe this will filter into the rest of, if they get the results, they can see the statistics, they can see, yes, these health outcomes are improved and we're saving money, and, it will roll out into other areas of the healthcare industry as well. So
And exactly what you said, Jennifer. It's opening up, right? It's filling these gaps that we know we have in the outpatient arena, right? And this will fill that gap that if we can get more people into this as a career,
mhm.
right? That they get trained, they're care navigators, it it fills that gap for patients, for our healthcare system, which is what we want, is what we're finally seeing is that CMS is looking at that outpatient arena and going, how do we fill in all of these gaps? And this is one way.
Yeah, yeah, perfect. Okay, so who is able to get these services, the PIN services? So patients with a serious high-risk condition, illness, or disease with the following characteristics. So it's one serious high-risk condition, um, and for and that could be many different things. And for the PIN PS, it has to be a serious high-risk behavioral health condition. These conditions are expected to last at least 3 months, and it places them at significant risk of, one of the following: hospitalization, um, transitioning to a nursing home, acute exacerbation or decompensation, or functional decline or death. And for me, that's pretty broad because so many conditions could fall under that. Functional decline, sure. Acute exacerbation, many, many things.
Mhm.
So, I think that that's pretty broad. And it's a condition that requires development, monitoring, revision of a disease-specific care plan, and may require frequent adjustment in the medication, treatment regimen, or substantial assistance from a caregiver. So again, lots and lots of things, fall under that. But Melissa, what do you think are list some of the, possible conditions that we all know about that you think would fall under this?
Right. And looking, I just want to make a point. A condition that requires development, monitoring, or revision of a disease-specific care plan. And so this again is where it can be limiting, right? So sometimes it's hard to, look at an acute exacerbation of congestive heart failure, right? Okay, so that might be one. We have that they're having this exacerbation, they're at risk for going into the hospital, right?
For sure.
Having functional decline, right? They can't breathe, they're not able to ambulate,
Mhm.
right? So that is one disease, but it's only addressing that disease process, which most likely they do have other things that also need to be addressed. And
Mhm.
so that's where this principal illness navigation, yes, we need somebody to step in and go, okay, we need to spend time and resources on assisting this patient and get reimbursed for it, which is all great, but what happens with everything else going on,
Yeah.
you know? And so that's one of my things when I read this, it works great in theory
Mhm.
that the cardiologist, right, can maybe right away go, okay, we're implementing, principal illness navigation codes because we're
Mhm.
doing this work. But what about everything else that's going on with the patient?
Yeah, absolutely. I mean, definitely think that's one of the limitations that we can see with this. It just, as patient advocates, it's the whole opposite mindset. I mean, we don't want things to be fragmented. We
Mhm.
look at the whole person, right? We take that holistic view and we get very involved with them. And this is just really piecemealing it down into one 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 disease, and that's really hard for
Mhm.
us and our mentality. And you just wonder, what that's going to look like in actual
Right.
practice. Like, how can you say, well, yeah, we're focused on your CHF, and I know you also need transportation to get to your, you know,
Dialysis appointment.
rheumatologist or yes,
Yeah.
dialysis or something, but
Right.
that's the kidney. I'm not
So
You've
it,
got to get your nephrologist to coordinate that, where it's like,
right.
no, I'm coordinating transportation. Why helping with that? Why can't I, do it for both conditions? It's that's
It,
the reality of it. Is that how it's going to play out? I don't know. I
right.
hope not. And I will talk a little bit about chronic care management, principal care management, and how they can, step in as well.
Step
But
in.
they're
Yes.
different. There are differences between all of these. So we will get to that later on. But give me some diseases. What are or illnesses that you think this is? We said, CHF, I'm
Yes.
sure
So I think of,
heart disease.
anything, right, cardiac. So then you think pulmonary, so exacerbation of COPD, right?
Mhm,
We said renal exacerbation,
mhm,
right? Neurological. So if somebody with dementia, right, is suddenly progressing, they're having delirium, right?
mhm,
They're not safe at home. That's a
mhm.
changing condition,
Yeah.
possible nursing home placement. So again, when I read this as a practitioner, as a nurse, it tends to be system based, right? So looking
Mhm,
at all those systems, what could be an exacerbation that would qualify somebody
mhm.
for this?
Yeah. And
So
we've already said
infection,
cancer.
somebody has an
Yeah.
infection suddenly from
Yeah.
something. Yep.
HIV, AIDS, and then the
Yep.
two for the PIN PS is substance use disorder. That's
Yeah.
actually,
Yeah.
covered, and then any severe mental illness too.
Right.
So,
That suddenly they've been diagnosed with this maybe for years, but now we're suddenly seeing such a change
mhm,
in their mental health, or that they're concerned that we need to hospitalize,
yeah,
they need to go into a different level of care.
mhm,
Um, yep.
yeah, good. Okay. So next one, how's it build? Oh, these are busy slides, guys. I apologize, but they are. So Um, I know you all want to know this. These are things we need to know. So it has to be a healthcare practitioner. So doctor, PA, NP, generally, those are the ones that are the billing practitioners for CMS. They initiate the PIN services. So there has to be an initiating visit where that practitioner identifies the medical necessity of PIN services, and they have to establish an appropriate treatment plan for the medical condition. And then the auxiliary personnel, so the PINs, the PIN PS, they jump in and they'll do the rest of the services. So then they'll do, the monthly calls with them or visits or, whatever it is. So the billing is always incident to that billing practitioner. The auxiliary person is doing, the care, but it's incident to that billing practitioner. The PINs can be external to and under contract with that office or practitioner. They don't need to be employed by them. They don't need to be on site. They can be a contractor. This is all billed. Maybe we should have said this in the beginning. This is all through Medicare Part B. So you have a 20% copay that is going to apply. You can do this telehealth. So that is good. And then you can bill only once per month. And at first I had said up to 1.5 hours, but I feel like you can only do one of those billing codes. So it's an hour or it's a half an hour. And so that's a limitation, unfortunately, because maybe it's not a limitation. It's a good thing, right? If we didn't have
Right.
this, it's better that we have this than we don't have this. But compared to what independent patient advocates do, how involved we get and how many hours we spend with our clients, especially when there's an acute concern or, a new client test, we're getting super involved. It's more hours than that, a lot more hours. You can only bill it's billed per serious high risk condition, and only one practitioner can bill per serious high risk condition. So if for some reason, you have some disease, some illness that two specialists are treating, only one of them can bill for the navigation services. PIN can be billed in addition to chronic care management billing and other services. Like I said, we'll talk more about that. And then these are the reimbursement rates. Now, as you know, CMS, their rates vary based on geography, but on average, it's 80 for the first hour of services for office-based practitioners, and then 50 for each additional half hour. And then facility-based practitioners, it's 50 for the first hour of services, and then 35 for each additional half hour. And they do that, the difference between office-based and facility-based, because they believe that in the facility, they're going to be billing for other services like chronic care management, and you're getting other services that CMS is reimbursing for that overlaps with these PIN services. That makes sense to everyone. So I'm just going to give you, one sentence that they have in their guidance, and they say beneficiaries can receive more than one PIN service at a time, as long as the services are not treating the same condition or furnished by the same practitioner. So you can have PIN services by the cardiologist, addressing CHF and all the needs related to that. You can have PIN services billed for, by the nephrologist for your end-stage renal disease, but they're separate conditions, separate providers. Yeah, so Melissa, do you see this as something that patient advocates could become involved with? What are some of the caveats that you would offer to advocates, or some of the challenges that you would see for advocates, working as a PIN? I
I
know
mean,
that's,
honest, yeah. When I
yeah.
first see all this, I go, it's better than nothing, right?
Yeah.
It's better than nothing for our patients and for those who are working in office-based, offices and facilities,
Mm-hmm.
right? So it's a starting point for them when they're offering these services to get reimbursed. As far as independent patient advocates, this is very limiting. It's very
Mm-hmm.
limiting to us because this is, the majority of people do not practice this way.
Right.
We don't limit to one disease process. We don't limit the time,
Time.
that we spend because, 1.5 hours can go by very quickly.
Mm-hmm.
So it's very limiting. If you truly want to practice patient advocacy, um, the way we sort of teach advocacy, right, is where you're doing an assessment, a very thorough assessment, getting the whole picture of
Mm-hmm.
one's, health and well-being, which does address the social determinants of health along with these disease processes, right? We're doing that initial assessment, and then we're coming up with a care plan to address. So very similar, right, to a provider all providers do assessments,
Mhm.
all providers do a care plan, and then it's actually implementing that care plan, right? And that's where that implementation of a care plan, this time constraint, is very difficult, right? Because
Yeah.
1.5 hours is not going to get us very far to
Mhm.
implement a lot of the services that our clients and patients need, let alone, give us time to evaluate if they're working and to go back and change our care plan and go down maybe another road.
Yeah.
So, it's definitely when we're looking at this, we need to look at it from this provider standpoint. What
Mhm.
does it mean for the providers that we're working with as independent advocates? Along with then how do we differentiate what we're doing compared to what these PIN services offer?
Yeah, absolutely. Okay. So another busy slide, but this is, what people who have been
Yeah.
working in healthcare and working with patients, we know that there's all these care management, options out there for patients. And so these are some of the ones that, are related to the PIN services, the health equity, um, physician fee schedule. Um, and so what do we have to say about, I don't know if you want to go through this slide or just talk about it in general, but what do we think about the relationship between PIN and all of these care management services?
So if you're trying to understand principal illness navigation, you really need to back up and understand transitional care management, principal care management, and chronic care management because these were rolled out years ago.
Mhm.
And you need to know, okay, so for example, if you have a client, right, who goes to the primary care, have they been enrolled in chronic care management? You should know that as an advocate because your client should have signed a consent
Mhm.
and you know that the person you're reaching out to at that primary care office is the designated staff member
Mhm.
that does the chronic care management. So I just wanted to make sure that as we talk about principal illness navigation, if you're not familiar with TCM, PCM, CCM, that you go back and you truly understand what these are and how they can benefit your patients or your clients. And so that's really, and when you're seeing the PIN services, is that what, happened was CMS rolled all of these out. And even these have evolved,
Mhm.
and changed over the years as they've been collecting data. Mainly the data is, are we having decreased hospitalization? And have there been any cost savings to implementing these care management services? And some of what we do as independent advocates is care management. We
Mhm.
will hear people say, oh, I'm doing a lot of this care management for clients. Yes, we do. And so there's a lot of overlap between an independent advocate and these care management services, along with advocacy and principal illness navigation.
Mhm. Yeah, these are great. And the details are important. When I was just reading about this, because this isn't completely my area of expertise, is chronic care management, that's if you have two or more conditions not being treated, under principal care management, then that's, what you would be using and billing under. And then principal care management, again, is one high risk condition. With those two, the billing practitioner needs to be pretty involved. They're involved in creating the care plan. Clinical staff is very involved. It's mostly billing based on clinical staff time. Clinical staff can be, kind of broadly defined, and that's something you all can look up, with what CMS has to say about it. But that's, there is a little bit of a difference there. I mean, we went over the training for the PINs and what they require. None of that says you have to have a clinical degree, right? So certification, training, but it doesn't say you have to have a clinical degree. Whereas other than the billing practitioner, the initiating practitioner. But these two, it's a little bit of a different focus. But they can work together. Like
And
you've
there's a lot of
said.
overlap, and they
Yeah,
could all
there's
work
over.
together.
Hmm.
And so then it's going back into like, well, what does this really look like? And we're going to dive into in our last session is sort of come up, with a case scenario where you can
Yes.
actually see like what this looks like that somebody you're working with, is in that transitional care management along with the principal care management because they had an exacerbation of a disease process that now the oncologist or neurologist are, managing, along with chronic care management being done by the primary care provider.
Okay.
Because as we mentioned that, two disease processes, and most likely if they have two, they have four. you know so there's a lot of overlap, and unfortunately what happens though for providers, especially when these new fee schedules come out, is there's intense work that needs to happen in that provider's practice to understand, one, it took them time to understand this billing, right? And how to actually implement it into their practices. And now when we see new codes coming out, they need to invest time and money in their office practice, or their, a larger system has it a little bit easier, right? Because if a system has coders and billers, they can absorb a lot of that, for multiple practices. But if you're a, you know mom and pop kind of practice, implementing all these new codes and understanding them, it's time and money for that practice.
Mhm.
So it's, again, it's a great thing, to offer care management services. But it's also, we need to recognize that not all providers can offer them, due to their time constraints, money constraints.
Mhm.
So if you're working with somebody, it's just knowing maybe when you're vetting out, a practice, do you implement any of these care management services?
Mhm.
One way is if you go to an appointment and they ask them to sign a consent.
Yeah, that's right.
That's the one way, you go, oh, what are we consenting to? Oh, you are now consenting that this one provider is going to be providing your chronic care management.
Mhm.
And and ask, what does this actually look like? you know who's the person that will be overseeing it? Is that the person I contact when I notice that my client is having issues with the medication, or a change in condition? So
Yeah, what does that mean for the patient? Yeah, what are they
yeah.
eligible for? Who do they go to for, certain questions? I mean, that's all part of the maze of this lovely healthcare system, right? It's like,
Yep.
oh. Okay, so we wanted to share a few things about our resources. So a lot of that information came from this first document from the American Society of Clinical Oncology, the Care Management Services and Patient Navigation Services, a comparison. So we'll try to make sure that that link is wherever we're posting this on social media, so you can have that, but you can also just Google that, and I'm sure you'll
Yeah.
get the PDF to pop up. We also created a 3-page resource list for a lot of the sites that and documents that we used to inform ourselves. So CMS based, but also a lot from the oncology world and other places about all that we're going to talk about in this 4-part series. And if you go to the link, then it will take you, to that PDF. But we will have that available for you um, to see. So, that's the end of that share.
Yes.
Let me see if I can show, whoops,
Well, and
the,
just to comment about the resources is that when we started diving into all of this, we're seeing more and more stuff, being put out there. This is just something I found that it was just updated. As you can
Mhm.
see, it's
Yeah.
probably one of the latest resources that I found that actually dives into all these things that we're talking about in this series, right? Social
Mhm.
determinants of health, principal illness navigation, community health integration, which is our next topic that
Mhm.
we're going to dive into. So, as far as resources, they are ever changing because this new fee schedule just came out in the beginning of 2024.
Yeah.
And you can see here, they also reference care management.
Yep.
So you've got to understand care management if we want to understand the new fee schedule that was put out there.
Yeah.
So we created our own extensive resource list that is 3 pages long, thanks to Jen. And then this just came under our radar that we're adding to it. And we want you to have these resources so you can, you know, read about, research, try to understand. So you're educating yourself. So when you're in the community representing patient advocacy, you can have conversations
Mhm.
with others. And all just going back to is how does this benefit patients and clients and families that we work with?
And you've talked a little bit about, I mean, throughout this conversation is how do advocates, how can this help them and their clients? What do we go forward? What lessons have we learned, about this and how independent patient advocates can, work with PIN services, PIN navigators? I mean, what are your thoughts on that?
Yeah, I think it just comes again from having that dialogue as you're working with a client, understanding, when your client is, say, in the hospital and then being discharged and then going to their follow-up appointments to their primary care and all these specialists. And
Mhm.
as they're been, bombarded with signing forms, and what are they consenting to? Are they consenting to, chronic care management services? Have
Mhm.
they, been assigned somebody at the office to reach out to?
Yeah,
Right?
good. Yeah.
Are they, do they have navigator services being offered, and who's that being offered by? Is it being offered by the actual, specialist office, or is it being offered to the clinic that they're receiving therapies from?
Mm.
So, when we're working as an advocate, these are all services that can benefit and help
Yeah.
our clients, but we
Mhm.
need to be educated. We need to understand, we talk about insurance, right? And you need to understand insurance, which is really complicated.
Yeah.
So, and again, we don't have all the answers, and that's why we're here today. And we just encourage you to educate yourself and then, create dialogue with others. And if you want to join us, if you have, any resources that you want to share, reach
Experience
out
with
to us.
actually doing this and billing it
Yes.
and whatever. Maybe your client,
Yes.
had a navigator or you are whatever it is, let us know. We're
Yeah.
happy to, yeah,
Yeah.
to hear from you and incorporate you into the conversation and your information. Yeah, so that's been a lot,
Yeah.
which is good. But we have two more of these that we have scheduled. So after this pin, we're going to talk about community health integration and community health workers, and that is a whole different ballgame because they do have an established workforce, um, certifications, licensures in different states, and we
Yeah.
have it in Arizona. So we have a lot to talk about regarding that. Um, which has a little different spin on it. So that's pretty exciting. But thanks everyone for listening. And you know, if you want to get notified, when these the next two drop, you can subscribe to the YouTube but we'll put it out there on everything else. So don't worry, it'll be out there for sure so that you can see it.
Yeah.
Anything else, Melissa?
No, that's it.
Yeah. All right,
It's been great.
everyone. Thanks so much. Have a great day.